Hello everyone, and I hope everybody is doing perfectly fine. So today here I am again with the lecture in continuation with my topic, that is anemia. So in my previous lecture I had taken just a brief or introduction to anemia, you can say, like how we approach it and what is the basic thing which we should know about anemia overall. So today we'll be starting with the main topic, that is one major type of anemia, that is iron deficiency anemia. So what you should know about iron deficiency anemia to begin with, as we all know, this is the most common nutritional deficiency worldwide, and it is common in those countries where hookworm infestation is known to be endemic. Now basically there are few reasons why there are risk of developing iron deficiency anemia. See, decreased availability of dietary iron or chronic blood loss from in any reason, maybe parasitic infection or chronic GI blood loss or any kind of blood loss which is leading to decrease in iron load in our body. So when we consider in general pathology, we know that whenever we study a disease, we have to read it under four main headings. That is etiology, padhoge aap, pathogenesis, clinical features, and then we go for the treatment. Fine. So main etiology, as we know, that first हमारा था dietary deficiency. So dietary deficiency क्या-क्या causes हो सकते हैं for iron deficiency anemia? It can be because of inadequate diet during infancy when there is increased demand of iron. So these few conditions, just infancy, pregnancy, then adolescent period. So these are actually period when iron requirement is increased in our body. Okay? Then socioeconomic status. Socioeconomic status means they are not able to provide proper nutrition, and in consequence what happened? There is dietary deficiency of iron. Then second broad category is blood loss, जिससे हमारा iron overload कम होता है. ठीक है, iron load कम होता है body में. एक तो blood loss, inadequate diet, then chronic blood loss. ब्लड लॉस से क्या हो रहा है? एक तो chronic blood loss अगर हो रही है from GIT, gastrointestinal tract और genitourinary tract, so there can be numerous GI causes जैसे कि peptic ulcer, hiatal hernia, malignancy, alcoholic gastritis, excessive salicylate ingestion, hookworm infestation, and hemorrhoids. So these are few conditions which causes the GI causes which leads to blood loss and resulting in iron deficiency anemia. And sometimes in women of childbearing age also, as we know, iron is lost through menstruation. Then another category is hemodialysis. जो patient hemodialysis पे होते हैं, उनमें क्या होता है? There is loss or decreased production by kidney of what? Erythropoietin hormone. ठीक है? So erythropoietin hormone कम हो रहा है in hemodialysis patient. तो इसलिए इन patient को हम recombinant human erythropoietin भी देते हैं to increase erythropoiesis. Then malabsorption, it is not an usual cause of iron deficiency anemia. We'll read it in subsequent types of anemia. So what we saw, pathophysiology क्या है? अगर आप देखो iron deficiency की, क्यों होगा iron deficiency? जब हमारा total first important cause when our total body iron content is diminished. And you know, iron deficiency anemia ना suddenly नहीं हो सकता कि suddenly patient is presenting you with iron deficiency anemia. It develops in stages. एक sequential order follow करता है iron deficiency anemia to give you overt symptoms of iron deficiency anemia. So initially क्या होता है? Period of negative iron balance होता है, which the body tries to adapt. Then losing more iron than is absorbed in gut results in negative iron balance, and consequently you get iron deficiency anemia. So as I said कि एक sequential development होती है iron deficiency anemia की. So we know iron deficiency anemia develops in 3 stages. तो frank iron deficiency anemia से पहले we have stage 1 and stage 2. So stage 1 is iron depletion, जहाँ पे हमारे जो storage form of iron है वो deplete होना शुरू होते हैं, like ferritin, hemosiderin. Fine. Second is what? When iron depletion हो रही है body में, सेकेंड स्टेज में क्या करता है कि बॉडी इवन ट्राइज टू कंटिन्यू विद द प्रोसेस ऑफ एरिथ्रोपोइसिस. सो दैट स्टेज इज योर स्टेज 2, आयरन डेफिशिएंट एरिथ्रोपोइसिस. उसमें भी अगर नहीं कंट्रोल हो रहा, देन द पेशेंट डेवलप्स iron deficiency anemia, which is frank. So this IDA, this is our iron deficiency anemia, can range in severity from reduced iron stores, जो कि stage 1 है, with no functional defect in stage 1 and 2. Severe anemia with deficiencies of tissue iron containing enzymes, that is stage 3 or frank iron deficiency anemia. So stage 1 को पहले हम पढ़ते हैं, that is what is the basic pathophysiology which is happening in stage 1. As I said, iron depletion हो रहा है, storage iron नहीं है. So iron stores are exhausted. There is decrease in serum ferritin. There is but no overt anemia in patient. When you examine the peripheral smear, erythrocyte morphology is normal. You get normocytic, normochromic blood picture. Then RDW, ये important है. That is red cell distribution width. ये what it denotes? It denotes the variation in size and shape of your RBCs. So increase RDW, it means there is some change in this shape and size of your RBCs. So increase RDW अगर हो रहा है, that can be a first hematologic indication of developing iron deficiency anemia in non-anemic patient. Then comes your stage 2, जब हमारा iron store deplete हो चुका है. Stage 2 क्या है? Iron deficient erythropoiesis is going on. So here what happens? There is no sufficient iron which should be inserted into protoporphyrin ring to form heme. Heme, this is a pathway that I will show you somewhere in my lecture कि जब हीम बनता है उसके लिए आयरन का इंसर्ट होना जरूरी है इन प्रोटोपोरफायरिन रिंग. So क्या होगा? Iron is not able to insert. There is no iron, so it is protoporphyrin levels are free. So what happened? Protoporphyrin accumulates in the cell and it combines with zinc to form zinc protoporphyrin. ठीक है? Bone marrow sideroblasts are absent क्योंकि storage iron गायब हो चुका है. Macrophage iron is not seen in marrow. Anemia and hypochromia are still not seen in peripheral blood. Whatever the changes are occurring, it is occurring at the level of bone marrow. But what we can see on peripheral smear, that RBC size are slightly getting smaller, microcytic appearance. Then you have reticulocyte जो होता है just a precursor of your immediate precursor of your mature RBCs. ठीक है? तो उसका अगर hemoglobin content हम देखते हैं, so hemoglobin content of reticulocyte, that is your CHR, that actually denotes the functional availability of iron during hemoglobin synthesis. So now it can also decrease even when anemia is absent. तो ये भी एक initial marker है, ठीक है? Decrease in hemoglobin levels of reticulocyte. Then comes your stage 3. That is frank iron deficiency anemia. So long standing iron, negative iron चल रहा है, deficit चल रही है, तो finally it will lead to iron deficiency anemia. So here when we do the blood test, जो भी parameters हम देखेंगे, how we approach or what is the lab diagnosis of microcytic hypochromic iron deficiency anemia. So all those blood tests will be abnormal. So and blood picture जब हम peripheral smear देखेंगे, so it will show us, RBC will show us the classic microcytic hypochromic. So now we are done with the three different stages of iron deficiency anemia. Now we see when frank iron deficiency anemia is there. So अब क्या होगा? So now what we'll be seeing is what are the different clinical features with which a patient of iron deficiency anemia present with. So as we know, iron deficiency anemia, it has an insidious onset. It gradually it occurs and occurs over a period of time. आराम से होता है ये, ठीक है? Stage 1, stage 2, stage 3. As anemia develops, so frank IDA होगा तो patient will develop clinical sign and symptoms. So koilonaikia is club-shaped spoon, ठीक है? Then glossitis, pharyngeal webs, muscle dysfunction, inability to regulate body temperature when cold or stress, and also gastritis. So pica, that is also a very common term which you use it for symptoms of iron deficiency anemia. Patient will say they have an unusual craving for eating unnatural items like जैसे ice eating होती है, they have, that is known as phagophagia. Patient has habit of eating dirt, clay, that is geophagia. Then some patient have complaint of starch eating, that is amylophagia. Then iron deficient infants, they perform worse in mental and motor development. Symptoms in children can be irritability, loss of memory, or difficulty in learning. And what we know is that when iron stores are depleted, so other metals get absorbed and that leads to toxicity of those metals like cadmium, lead, plutonium, etc. So see, just a rough diagram I had shown you this. See here what happened is, So this is your stage 1 deficiency. Stage 2, that is iron deficient erythropoiesis. This is frank IDA. So पहले क्या होता है कि हमारा स्टोरेज आयरन जो होता है वो डिप्लीट होना शुरू होता है, वो कंप्लीट हो जाएगा, स्टेज 1 में खत्म हो जाता है. देयर इज नो स्टोरेज आयरन इन स्टेज 2. So that is all finished in stage 1. Then second वो आता है ट्रांसपोर्ट आयरन ऑल्सो स्टार्ट्स डिक्रीजिंग, एंड स्टेज 2 के बाद धीरे धीरे ये डाउनफॉल हो जाता है इसका भी. Then stage 3, everything comes down. Hemoglobin, everything comes down. So this table is very important. Fine, this I have made. So see, just what parameters you have to remember. Male hemoglobin, female hemoglobin. उसका मैंने normal reference range दिया है आपको, ठीक है. Stage 1 and 2 में क्या होता है, जो male hemoglobin, female hemoglobin, in stage 1 and 2 it remains normal. In stage 3 it is decreased. देन आरबीसी मोफोलॉजी जो नॉर्मल क्या होती है, नॉर्मोसिटिक नॉर्मोक्रोमिक, वो स्टेज 1 एंड 2 में नॉर्मोसिटिक नॉर्मोक्रोमिक ही रहेगी. एंड इट इज एनसी दैट इज नॉर्मोक्रोमिक, सॉरी एमसीएचसी, माइक्रोसिटिक हाइपोक्रोमिक हो जाता है ये. आई हैव रिटन शॉर्ट फॉर्म हियर. देन सीरम आयरन लेवल्स, नॉर्मल रेंज होती है मेल में 65 to 180 माइक्रोग्राम पर डेसीलीटर, फीमेल इट इज 50 to 180 माइक्रोग्राम पर डेसीलीटर. दिस इज नॉर्मल इन स्टेज 1 सीरम आयरन, but it is decreased in your stage 2 and stage 3. Then coming to TIBC, that is total iron binding capacity, 250 to 450 होता है normal. It is increased in iron deficiency anemia. Stage 1 में slightly increased होता है और normal हो सकता है. Stage 2, 3 it is increased. Serum ferritin, storage iron, it is decreased all throughout stage 1, 2, 3. Normal levels also you should know. Serum ferritin should be 20 to 300 microgram per liter in male and 12 to 200 microgram per liter in female. So please be well versed with your units. Then saturation, it is in percentage. Male का iron saturation होता है 20 to 45, female का होता है 15 to 45. So this is normal in stage 1. Stage 2, 3 it is decreased. Zinc protoporphyrin microgram per deciliter में unit होती है इसकी, मेल में it is 1 to 27, female it is 11 to 45. As I said, जब आयरन नहीं होता है प्रोटोपोरफायरिन रिंग में इंसर्ट होने के लिए, सो प्रोटोपोरफायरिन लेवल्स आर फ्री, दे कंबाइन विद जिंक, देन फॉर्म जिंक प्रोटोपोरफायरिन. सो जिंक प्रोटोपोरफायरिन लेवल्स जो होते हैं वो आयरन डेफिशिएंसी एनीमिया में बढ़ जाते हैं. इट इज एन इंपॉर्टेंट मार्कर, सो इट इज इंक्रीज्ड इन ऑल द स्टेजेस. देन सॉल्यूबल ट्रांसफेरिन रिसेप्टर्स, ठीक है. सो बट जब वो आयरन ही नहीं है तो जो ट्रांसफेरिन रिसेप्टर्स होंगे दे विल बी मूविंग फ्री, फाइन. So that is 1.15 to 2.75 milligram per liter. So this is normal in stage 1 and it is increased in stage 2 and 3. Then transferrin receptor index होता है 0.63 to 1.8. This is also increased in your all stages of iron deficiency anemia. Now coming to lab, ये जो मैंने टेबल में समराइज किया था, this is the elaborate form which I am discussing now. So laboratory feature, जब हम peripheral blood देखते हैं तो हमें जो आरबीसी इंडाइसेस है हमारे, फर्स्ट एमसीएचसी जो मैंने लिखा है, दिस इज माइक्रोसिटिक हाइपोक्रोमिक ब्लड पिक्चर, ठीक है. देन कम्स योर आरबीसी इंडाइसेस, एमसीवी, एमसीएचसी, एमसीएच, ये सारे लेवल्स रिड्यूस्ड हैं. जो सारे लेवल्स मैंने रिड्यूस लिखे हैं, प्लीज चेक विद द नॉर्मल लेवल्स, ठीक है. एमसीवी 55 to 74 femtoliter, it is decreased. MCHC, it is decreased 22 to 31 gram per deciliter. MCH, that is 14 to 26 picogram. देन ब्लड पिक्चर में हम क्या, माइक्रोसाइटोसिस, आरबीसी साइज जो होती है वो रिड्यूस हो गई है. एनाइसोसाइटोसिस में साइज जो होती है आरबीसी को, उसको कहते हैं एनाइसोसाइटोसिस. पोइकिलोसाइटोसिस डिफरेंट शेप्स के होते हैं आरबीसी, जैसे टारगेट सेल्स, एलिप्टोसाइट्स, टीयर ड्रॉप सेल्स. ये तीन जो है मोर कॉमनली वी सी इट इन आयरन डेफिशिएंसी अनीमिया. Then increase REW I had discussed, and decrease in hemoglobin concentration of reticulocytes, which are the just immediate precursor of your mature RBCs. So see in this picture. See, when you have to compare the RBC, तो हम उसको करते हैं nucleus of lymphocytes से, ठीक है. So अगर nucleus of lymphocyte अगर देखो, ठीक है, तो RBCs आप देख रहे हो, all these RBCs are microcytes, hypochromia. पिंक जो हमारा नॉर्मल सेंट्रल वो होता है पिंक, वो नहीं हो रहा. हियर यू सी टीयर ड्रॉप सेल्स, ठीक है. टारगेट सेल्स कैसे होते हैं, आई विल शो यू. टारगेट सेल्स होते हैं जैसे कि आपने एक वो बनाया, दिस इज अ आरबीसी एंड हियर यू गेट अ डॉट, ठीक है. सेंट्रल डॉट होती है आरबीसी में. टीयर ड्रॉप, जस्ट लाइक टीयर ड्रॉप्स होते हैं, ठीक है. This should be in this circle, center should be here. Okay? This is the target cells. So here see, this is the RBC, lymphocyte nucleus, and this is all smaller. ठीक है, target cells ये हैं. देखो एक central dots आ रहा है. This is target cells. Pencil cells और elliptocytes होते हैं इसमें. ठीक है, सब teardrop cells होते हैं. So all those nice, this poikilocytosis, they create this by having different shapes. So now RBC is done. Whenever you see peripheral smear, you have to describe peripheral smear under 3 headings. First is your RBC. RBC we are done. Second important component is our WBC. The leukocyte count is usually normal, can be increased. Kyun? Because of chronic stimulation of our marrow in long-standing cases or after hemorrhage. Even with hookworm infestation क्या होता है? Parasitic infection है, उसमें eosinophils बढ़ते हैं, तो patient can present with eosinophilia also. Then third important component when we describe our peripheral smear is platelet count. So in iron deficiency, platelet count can be normal, increased or even decreased. Then comes our iron studies, which is important. Iron deficiency आप करोगे, हमने पढ़ा है उस table में. All the parameters I have given you with the normal values and stage wise I have mentioned in which stage what it is decreased. So please remember that table. Then serum iron, it is decreased, which is less than 30 microgram per deciliter. TIBC is increased. Saturation, transferrin saturation is decreased to less than 15%. Serum ferritin is decreased in all stages of iron deficiency. See, serum ferritin is normal too. It is an important, serum ferritin jo hai, it is important parameter to distinguish iron deficiency from anemia of chronic disease and other anemia where you have microcytic hypochromic picture. So anemia of chronic disease may increase hota hai, and it is also increased in your sideroblastic anemia and thalassemia. Then soluble transferrin receptors and zinc protoporphyrin levels are increased in IDA. Then coming to bone marrow, sometimes see, bone marrow examination is not mandatory for diagnosis of iron deficiency anemia, but we should know and we should have an idea that what is happening in our marrow in iron deficiency anemia. Okay, iron studies, peripheral smears, so those levels are more than enough to lead a diagnosis of, to make a diagnosis of iron deficiency anemia. So, but in marrow picture आपको पता होनी चाहिए होता क्या है. So marrow में we have total cellularity will be increased with mild to moderate erythroid hyperplasia. Marrow में हम दो चीज देखते हैं, myeloid and erythroid components. So there is decreased ME ratio, means erythroid अगर hyperplasia हो रही है तो myeloid के percentage obviously कम हो जाएगी, so ME ratio will be decreased. And see, peripheral blood glucose reticulocytes नहीं बढ़ रहे, even after we are saying here कि erythroid hyperplasia हो रही है, ठीक है, तो क्या होगा, reticulocytes को आना चाहिए ना blood में, peripheral smear में, but that is ineffective erythropoiesis which is going on. So there is no increase in peripheral blood reticulocytes. ठीक है, and you can have erythroid nuclear abnormalities. Ineffective erythropoiesis हो रही है, तो जो erythroid cells होते हैं, they will present with your nuclear abnormalities like budding, karyorrhexis, nuclear fragmentation and multinuclearity. Then when we look for iron in bone marrow, जब हम special stain use करते हैं, जैसे Pearl stain we use it for detecting iron. So they will show absence of hemosiderin in macrophages and sideroblasts are markedly reduced. So coming to, once you have made the diagnosis, we need to have an idea about what therapy should be given to iron deficient patient. See, establish the cause. Iron deficiency, पहले आपको establish करनी होगी, yes, patient is having iron deficiency anemia. We have to address any underlying disorder, उसको ठीक करना होगा, whether patient is having underlying bleeding or peptic ulcer. Then we need to administer iron. There are two ways, एक आप orally दे सकते हो या IV से दे सकते हो. Observe the response also. So 4 heading, ये important है. Establish the cause of iron deficiency, address the underlying disorder जिसकी वजह से iron deficiency हो रही है. You give iron and then you have to observe the patient for their response, whether their levels are being corrected or not after you administer iron. Usually what happens after we give oral administration of ferrous sulfate, so there are different salts of iron, how we give it, fine. It needs to be given in salt form. So IV is rarely required, but हमने पढ़ा था जो chronic renal disease वाले patients होते हैं जिसमें हम recombinant human erythropoietin देते हैं, उनमें IV dextran देना पड़ सकता है. Then see, another important point was कि after we give therapy, we have to look for the response to iron therapy, whether patient is actually improving or not. सो इम्प्रूव कैसे होगा? अगर आप 1 मंथ के बाद उसका हीमोग्लोबिन कराओगे, इट शुड बी इंक्रीज्ड बाय 1 ग्राम एट लीस्ट. ठीक है. रेटिकुलोसाइट रिस्पॉन्स जो होती है वो जल्दी शुरू हो जाती है इवन आफ्टर 3rd डे of your starting the therapy, and it reticulocyte response आना शुरू हो जाता है at 3rd day and peaks at about 9 to 10 days and declines after that. क्यों? क्योंकि normal mature RBCs आना शुरू हो जाएंगे and 6 to 10 weeks में your hemoglobin rises to normal. But will you stop it after hemoglobin rises to normal? No. To restore, you have to restore the iron store also. Fine. So we have to give an extended therapy with small amount of iron salt, which may be required sometime. So this was all about our iron deficiency anemia, and in gradually when I'll be covering the other different types of anemia. So if any point is missed out here, so I shall be discussing that also. And next class I'll discuss about iron metabolism. That is very important. So thank you so much for your patient hearing. Please like, subscribe and share my channel. Thank you so much.